for epidemic-prone diseases has been activated towards COVID-19 response. The Integrated Disease Surveillance Program, IDSP, is being further strengthened with substantial digital inputs. Government of India e-initiatives. Government of India launched an online data portal of critical human resources for combating and contacting COVID-19. The dashboard contains the state-wise and district-wise availability of the large group of human resources for various activities to fight COVID. Training of healthcare professionals through online modules, integrated government online training platform has been emphasized. More than 20 lakh officers have been registered and trained themselves on this online module for capacity building to fight against the coronavirus pandemic. Now, the World Health Organization defines telemedicine as the delivery of healthcare services where distance is a critical factor by all healthcare professionals using information and communication technologies for the exchange of valid information for diagnosis, treatment, and prevention of disease and injuries, research and evaluation, and the continuing education of healthcare workers. The aim of advancing the health of individuals and communities. The Indian Space Research Organization, ISRO's telemedicine network, has expanded to connect 45 remote and rural hospitals and 15 super specialty hospitals to provide tertiary care. And so the patient who comes to the primary care hospital, is able to connect to the super specialty hospital and get care. Telemedicine practice guidelines was released on 25th March 2020. Amendment in the Indian Medical Council Professional Conduct Ethics and Regulation 2000 by Medical Council of India, enabling registered medical practitioners to provide healthcare using telemedicine. There is a provision for consultation. There is no provision for consultation outside the jurisdiction of India. This was released on 25th March 2020. The 7 elements of telemedicine practice guidelines are content. Is telemedicine appropriate or in-person consultation is required? Identification of the doctor and the patient. Consultation should be done after both the doctor and the patient have identified themselves. Mode of communication can be video, audio, text. Consent is implied when patient initiates it, but when the caregiver initiates it, consent has to be recorded. Type of consultation, first consult or the follow-up consult. Patient evaluation, professional discretion to gather the type and extent of patient information required to be able to exercise proper clinical judgment. Patient management and counseling, education should be incorporated with the management which is required. Now, COVID-19 telemedicine social distancing. Telemedicine can be used for management of chronic diseases like the bronchial asthma, hypertension, and diabetes mellitus. Individuals with these conditions are particularly susceptible to COVID-19, and hence management and disease optimization are important ways to reduce the severity. Telemedicine can also be used for providing psychological support to patients and their family members during COVID-19. It also helps in providing training for the caregiver as well as the caregiver as well as the patient, and especially for disabled children and elderly. Here, because of social distancing, these patients are very difficult to approach the hospital very often. So telemedicine can definitely be used for the first consult or follow-up consults. Emergency consultation. Telemedicine services should, however, be avoided for emergency care. And telemedicine consultation should be limited to first aid life-saving measures. In all cases of emergency, the patient must be advised for an in-person interaction with a registered medical practitioner. Prescription of medicines. This row is the medicines which are available over the counter. like paracetamol, lozenges. These medicines are those that can be prescribed during the first consult, which is a video consultation, and can be prescribed for follow-up. This is a list of medication that the registered medical practitioner can prescribe a patient who is undergoing follow-up consultation in addition to those who have been prescribed during in-person consult for the same medical condition. Prohibited list and RFP providing consultation via telemedicine cannot prescribe these medicines, and these medicines have a high potential of abuse, so they cannot be produced. Important exclusions in the telemedicine guidelines. Telemedicine cannot be the answer to all the problems that the patient has, and it cannot replace in-person consultation or emergency medicine. Digital technology should not be used to conduct surgical or invasive procedures. There is no provision for consultation outside the jurisdiction of India. Telemedicine registry and evaluation. Having registry where the telemedicine products are listed after evaluation from an expert panel will help the patient, donor, hospitals, telemedicine companies, and all stakeholders in the telemedicine ecosystem by having access to information and various products, their capacities, their strength and weaknesses. An alliance led by, supported by National Resource Center for EHR standards has come together to establish the telemedicine registry for India. Insurance Regulatory and Development Authority of India. Insurance Regulatory and Development Authority of India issued circulars to insurers to allow telemedicine whenever consultation with a registered medical practitioner is allowed to be included in the policy. Provision of allowing telemedicine shall be part of the claim procedures. October 1, 2020, telemedicine consultations will be covered under health insurance. The National Knowledge Network, Ministry of Electronics and Information Technology implemented it through National Informatics Center. The objective of the National Knowledge Network is to interconnect all institutions of higher learning and research with a high-speed data communication network to enable knowledge sharing and research. Many virtual classrooms have been set up in the country. The National Medical College Network has been set up by the NKN, and they interlink the medical colleges across the country to enable e-education and sharing of knowledge. One national research center has been identified, and there are 7 regional resource centers which are connected. Distance education and e-learning should be allowed, where online classes and conferences can take place for sharing of knowledge. These things can be webcasted and later produced for the people who are not unable to attend the conference at that time. National Rural Telemedicine Network. The setting up of the National Telemedicine Task Force by the Health Ministry of India in 2005 paved the way for the success of various projects like the ICMR, BRCs. Both the healthcare delivery and technology, a major role in this played by the NASA and ISRO in implementing it for disease screening and disaster management services. National Digital Health Mission, the Ministry of Health and Family Welfare, Government of India, has formulated the National Digital Health Mission with the aim to provide the necessary support for integration of digital health infrastructure in the country. This visionary initiative, stemming from the National Health Policy 2007 to digitize healthcare in India. The National Digital Health Mission is an initiative between many ministries and departments. Now, the National Digital Health Mission has building blocks like Health ID. All individuals will be provided with a unique Health ID. DigiDoctor, where all the doctors in the country, including the qualification, name of the institution, are included. The Health Facility Registry, where the hospitals are included. As I already mentioned, Health ID, doctors' information, the hospital's information, the personal records of patients, telemedicine, and e-pharmacy. I like to share a video where, as an ophthalmologist institution, we have done camps in the rural villages where we take specialist care to the rural villages. This is a remote village in Tamil Nadu where we conducted the camp. The specialists are not available there, so the patients attend the camp to take specialist care for eye testing. These are the waiting patients. A bus with the paramedical staff and equipment come there. Registration is done on electronic medical records. The visual acuity of the eye or the refraction of the eye is done. The auto refractor, then subjective refraction is done for this person at the campsite. And glasses are prescribed. We have a lensometer. If the patient has the previous glasses, that can be checked out. For all the old people who are not able to travel and come to the main hospital, this camp is very useful. And all the records are entered into the electronic medical records. And all the findings, ocular findings. Here, the anterior segment of the eye is examined. And the intraocular pressure is measured. Applanation tonometry is done to measure the intraocular pressure. So these findings again are entered into the electronic medical records. Fundus examination is done. Non-mydriatic fundus examination, where we do not apply drops, only dark adaptation is done. So the retinal details are seen. Then glasses are given at the campsite itself. Counseling is done if the patient has to come to the hospital. Here, teleconsultation is being done. A doctor from the base hospital talks to the optometrist and the patient and explains to them the need to come to the base hospital and how many days they have to stay, whether treatment is required, whether surgery is required. This interaction is between the doctor at the base hospital and patient, optometrist, and patient's attender at the camp. So everything is clearly explained to the patient before they come. Surgical patients for that day, if they want to come to the hospital, they're picked up by the van and taken. Eye care in remote areas. India is a country with diverse cultural heritage. The geographical location, remote and rural, already play a critical role in delaying the diagnosis in disease causing blindness. So we use mobile teleophthalmology screening. We are basically an ophthalmic hospital. I'm an ophthalmologist. I've been interested in community work, and we have been covering the villages near Chennai, Thiruvallur, and Kanchipuram. Future opportunities. Pan-African e-network, the Ministry of External Affairs for the Government of India is implementing the project through Telecommunication Consultants India, where we are connected to the African Union. 10 super specialty hospitals here provide teaching as well as clinical advice to these people. The SARC telemedicine network has been set up. The South Asian Association of Regional Cooperation, SARC, created an expression of the region's collective decision to evolve a regional operative formula. And this pilot project connects 1 or 2 hospitals in each of the SARC countries with 3 to 4 super specialty hospitals in India. So telemedicine is not only within India. We want to connect to the other countries also and provide expertise in terms of education as well as clinical advice. Thank you. I am an ophthalmologist from Champanetralaya, India, Chennai. Thank you very much for giving me this opportunity.
Thank you, Dr. Sheila John, for your informative presentation. And it is encouraging that India developed huge telemedicine network. Now the floor is open for comments, question, or suggestion. Anybody can ask question or comment to Dr. Sheila's presentation.
Thank you. From Rajshahi Medical College, Professor Jawad.
Yes, sir.
Thank you very much, Dr. Sheila John, for your nice presentation and attractive pronunciation. Thank you very much.
Thank you.
This COVID-19 pandemic gives us some life-threatening experience in our life. But if we think another way, if we think that COVID-19 gave us some teaching, that means we can think that we can be able to do something in future. It can give us some ability for projection in future, like telemedicine. You are presenting the paper, that is your, perhaps it is based on your experience, I think. It is not a original paper presentation, is it?
No, it is original paper presentation.
Original, but it is like a review article.
No, this is basically when you take telemedicine in India, what are the things the government has initiated prior and how they have taken all these projects, the March 2020 when they put in the guidelines, they've taken all the projects with them forward. Initially, they were in place and not much was being done. Even the coronavirus pandemic, they tried to do it digitally, putting all the officers and everybody who's available on the dashboard. So people can see who are the people who are available, which are the hospitals available, how much personnel they have in each state, so that if the pandemic affected state, whether they're well covered with the doctors, infrastructure, everything, they were able to project. So, and they were able
thank
to...
you. Thank you. Thank you very much. I think the presentation is very much important in current perspective. Now, beyond the COVID-19 era, we can think about the telemedicine regarding our new normal life. We can use it. Thank you very much.
Any more comments or question from anybody? If there is no question or comment, I shall switch over to next session.
I am Dr. Monirul Islam, Rationale Medical College. I have one question to Dr. Sheila John. Can you hear me?
Yeah, I can hear you.
Okay. I think this concept, telemedicine, is a new concept, I think. So what is your expectation of this telemedicine in future?
See, initially we have been basically doing telemedicine for more than 10 years. We have been having mobile vans, and we go into the villages with paramedical staff and equipment, and they take the necessary photographs, feed in the data into the electronic medical records, and bring it over. We were providing for the rural people, telemedicine was getting provided. Now for the paying patients also, people come attend the hospital and go. There are many elderly people, sick children, disabled children. So whatever the first consultation where they come, the follow-up consultations, as well as the advice which has to be given, whether the drops have to be reduced. Now we are trying to do it via teleconsultation. Earlier, we didn't have a legal document saying that telemedicine is accepted. Government has got it only in March 2020, 25th March. So now they've enabled it. So we are trying to expand to other specialties also. Not only in community ophthalmology, we are trying to do it at other specialties, but the First consult by the doctor, follow-up consults can be done. Because of social distancing, there are many people who are diabetic or immunocompromised. For them to come to the hospital, often they might get COVID. So telemedicine has to be taken up for those people.
Thank you. Any more comments or question?
Can you hear me, Sheila?
Yeah, I can hear you.
Yeah. Actually, in our country, we've been practicing telemedicine for several years too. You may hear one of our internet platform that we call 16263. That is a huge platform, and Bangladesh Health Ministry has been operating it for several years. And in COVID situation, it is already expanded. The challenges we are facing is related to three issues. One is the coverage, one is the quality of the services we've been providing through telemedicine, and the sustainability of the project. So would you like to share your experiences spearheading these three issues? It is obvious that for some specialized services and from selective services, telemedicine has no options, because we do not have sufficient amount of psychiatrists or disability-related services. So for coverage, telemedicine has no option. In terms of coverage, how can we cover at the primary healthcare level so that we can achieve universal health coverage, and the sustainability of the project and the quality, the perception of quality and satisfaction of the population, those who are getting those services. Thank you, Sheila.
See, if you see for ophthalmology, radiology, psychiatry, telemedicine is very good. Because if you take radiology and ophthalmology, they are all image-based. So you are able to even diagnose the patient. Only for investigations, you bring the patient over, telling the patient that you need surgery, you need this treatment, and then we take out. There are two concepts in telemedicine. One is having sort of a fixed facility. Another one is a mobile van. In a fixed facility, the thing is you cater to 50,000 population or 1 lakh population. You will have to have somebody there in person to do everything. And it caters to only that population. In a mobile facility, it is able to travel. You have a cycle. It starts in one place. You go to 20 centers or 30 centers, and then you come back to that center itself. And even in a disaster, suppose there's some disaster management, a mobile van will be able to reach. What basically you need is you train the paramedical staff to do everything almost equal to a doctor, except that the diagnosis alone comes to them. So you allow them. Nowadays, smartphones are very good. You can use that to exchange images. You can use your laptops, and equipment also comes where you can take photos of that structure and able to image. All that was not available about 8 or 10 years back. But now everything is feasible. Earlier, we used only ISRO connection, that is Indian Space Organization connection only we could use. We had to put a satellite on top of a bus and take that satellite wherever, and using the GPRS system, we were able to connect. But now that is not the case. I think internet penetration has come in many places, and phones are working almost everywhere. Even if you cannot do a video consult, you can do at least an audio consult. Explain to them, the people who require treatment are taken up. And now we have developed not an online EMR, where you feed in directly, it comes to the hospital. We have developed an offline EMR. That is, we keep a Wi-Fi connectivity in that camp or remote area. You connect 2-3 computers within there, and all the clinical data are fed in. One person does registration, another person does clinical history, another person whatever they're able to advise, and the third thing the doctor, and fourth thing the pharmacy. All these 4-5 computers are connected offline, not online. So you don't need internet connectivity at all. You just need a Wi-Fi router to connect these 5 things, and you get all the patient information there. You don't have to carry your paper records anywhere. Even if the patient shifts from that village to another village, you have the EMR thing, and next, so many paper files to be carried is not needed. So what we do is we do an offline EMR, we bring it to the hospital that day and upload it into our server. Every day we upload the thing. So it is also in our server. There we do not attempt it because some very remote areas do not have that. And then teleconsultation requires a certain amount of bandwidth, video conferencing. So if you are not able to do that, you can use your phone, do an audio conferencing. Maybe the number of patients who come over might be a little more. Instead of, suppose you do video conferencing, you can reduce it to 10. With the audio, you might have to bring in 20 patients. And there are so many things which have come up. And the villages also, now they have Gram Panchayat person that you leave your address, everything. So any treatment which is given, it's not working, they will immediately contact you on the phone. You send your vehicle and bring the patients immediately to the hospital for treatment. So everything can be covered now, which is earlier, 10 years back, it was really difficult. Now things have improved.
Okay, thank you, Dr. Sheila John. I think you will be connected with us.
Yeah, sure.
Now the presentation of Dr. Nazia Haq. She is working as an associate professor of microbiology in Sheikh Hasina Medical College of Jamalpur, Bangladesh. She is going to present on detection of novel coronavirus by RT-PCR in Mymensingh Medical College, Bangladesh. Dr. Nazia Haq.
Honorable Chairperson, respected audience from home and abroad, Assalamu alaikum and a very good morning. Me, Dr. Nazia Haq, Associate Professor of Microbiology, Sheikh Hasina Medical College, Jamalpur, welcome you all to this presentation on detection of 2019 novel coronavirus by real-time reverse transcription polymerase chain reaction at Mymensingh Medical College, Mymensingh, Bangladesh. The article is published in an index journal, Mymensingh Medical Journal, in 2020, volume 29. Me, Dr. Nazia Haq, is the principal author of this article. Other co-authors of this article are Dr. Mohammad Shafiqul Bari, Dr. Salma Ahmed, Professor Dr. Shamul Kumar Pal, Professor Dr. Syeda Anjuman Nasrin, and Dr. Mohammad Kamruzzaman Khan. With the permission of the chair, I like to start my presentation. The coronavirus disease, that is COVID-19, is highly pathogenic viral infection caused by SARS-CoV-2. The whole world has been afflicted by the torment of COVID-19 outbreak, which devastated tens of millions of people globally, since the World Health Organization declared it a pandemic on 11th March 2020. The human civilization have been held captive by the terror of this teeny particle of RNA. There has been extensive impact on health, including considerable death among older adults and those with pre-existent health conditions and consequences for the global economy. At present, the infection rate and death toll are on the rise among South Asian countries, including Bangladesh. According to report of Worldometer on 22nd June 2020, the virus has spread to at least 213 countries and more than 90,93,827 confirmed cases and 4,71,490 deaths have been recorded, with massive global increase in the number of cases daily. Worryingly, Bangladesh was among the fastest in the world to reach 2,000 cases, reaching the figure in just 40 days after its first case was detected on the 8th March. Now, virology of SARS-CoV-2. Coronaviruses are large, enveloped, non-segmented, positive-chain, single-stranded RNA viruses belonging to the family Coronaviridae order Nidovirales. A proofreading replicase maintains the solidity of the lengthy genome. The SARS-CoV-2 genome encrypts 11 open reading frames, some of which have unknown functions. This is the figure of SARS-CoV-2. Inside there is nucleic acid, that is RNA, and outside there are some protein like spike protein, envelope protein, and membrane protein. Because of rapid transmission and long incubation period, the containment of the disease is extremely difficult nowadays. The COVID-19 pandemic was confirmed to have spread to Bangladesh on March 2020. Bangladesh faces significant challenges in combating COVID-19 as it is a densely populated country and also houses a million stateless Rohingya refugees in sprawling refugee camps that are conducive to the spread of epidemics. It is also has significant migrant populations living in Italy, a COVID-affected country, and other European countries. Usually, this newly identified coronavirus has an incubation period of 2 to 7 days. There are no obvious symptoms that are observed during the incubation period. However, the mysterious virus is contagious and can spread from an infected person to a non-infected person during the incubation period through direct contact, aerosol droplets, and intermediate fomites. The usual symptom of COVID-19 includes fever, cough, shortness of breath, and muscle ache. Some patients may have sore throat, rhinorrhea, headache, and confusion a few days before the onset of fever, indicating that fever is a critical symptom, but not the only initial manifestation of infection. Diagnostic test for detection of COVID-19 is critical to tracking the virus, understanding epidemiology, informing case management, and to suppress transmission. There are some newly developed and promising methods to detect SARS-CoV-2 in order to facilitate the development of novel approaches for early diagnosis. Nucleic acid testing is reported to be essential for the early diagnosis and confirmation of SARS-CoV-2 infection. Among them, real-time reverse transcription polymerase chain reaction is the gold standard testing method for the detection of SARS-CoV-2. In this method, the SARS-CoV-2 RNA is first reverse transcribed into complementary DNA, and specific gene fragments within the complementary DNA are amplified using target-specific primers. The fluorescence signal, which represents the copy number of the target sequence, can be easily detected during the amplification process. This is the first baseline study for genetic detection of 2019 novel coronavirus in Mymensingh division, which may reflect the total scenario of Bangladesh situation. General objective of the study was to detect 2019 novel coronavirus by real-time reverse transcription polymerase chain reaction among the clinically suspected patients of COVID-19 in Mymensingh division. Specific objectives of the study were to detect 2019 novel coronavirus causing COVID-19 by real-time reverse transcription polymerase chain reaction, to analyze the socio-demographic data of the PCR positive cases in context of age and sex, and to determine the burden of COVID-19 positive cases from 4 different districts of Greater Mymensingh division. Now, materials and methods. This cross-sectional descriptive type of study was carried out in the Department of Microbiology, Mymensingh Medical College, Mymensingh, Bangladesh, from 1st April 2020 to 31st May 2020. A total of 14,356 nasopharyngeal swabs were taken from clinically suspected patients of 4 districts of Mymensingh division, namely Mymensingh, Jamalpur, Sherpur, Netrakona, and some part of Sunamganj, irrespective of age and sex. Each and every specimens were coded, numbered, and stored in computer accordingly to prevent recessive repetition of the samples. Negative patients were not followed up with real-time reverse transcription polymerase chain reaction, but all positive patients were followed up 14 days after positivity. Inclusion criteria of the patients were patients having either history of fever, cough, respiratory distress, travel history, or contact history with migrant population living in COVID-affected country within 2 weeks. All the data were collected in a pre-designated data sheet, and all collected data were analyzed by computer-based program Statistical Package for Social Science Windows version 22. Qualitative variables were summarized by percentage, and quantitative variables were summarized by mean and standard deviation. Now, specimen collection and transport. All appropriate specimens, that is nasopharyngeal swabs, were collected for laboratory investigations, were regarded as potentially infectious by trained healthcare personnel, following adequate standard operating procedures for infection prevention and control guidelines. Specimens for virus detection were reached to the laboratory as soon as possible after collection, following correct handling of specimen during transportation. Specimen to be tested were processed immediately. Repeated freezing and thawing of specimens were avoided to get better results. National guidelines on laboratory biosafety were followed in all circumstances. Specimen handling for molecular testing was done in biosafety level 2 following appropriate biosafety practice. Now, real-time reverse transcription polymerase chain reaction assay for detection of 2019 novel coronavirus was performed by Sansure Biotech Novel Coronavirus Nucleic Acid Diagnostic Kit. The Director General Health Service of Bangladesh provided the real-time reverse transcriptase polymerase chain reaction reagents. Now, principle of the test. By applying real-time fluorescence quantitative RT-PCR technology on the fluorescence qualitative PCR instrument, the test utilizes the novel coronavirus ORF1AB and the specific conserved sequence of coding nucleocapsid protein N gene as the target regions, which are designated for the conserved sequence of the double target genes, to achieve detection of sample RNA through fluorescence signal changes. In this PCR detection system uses the positive internal control, which detects the presence of PCR inhibitors in test specimens by detecting whether the internal control signal is normal to avoid false negative result. These are the components of the diagnostic kit. This kit is an amplification reagent which contains the following components like 2019 novel coronavirus PCR mix, 2019 novel coronavirus enzyme mix, 2019 novel coronavirus PCR positive control, and lastly 2019 novel coronavirus PCR negative control. Test method includes reagent preparation, processing and loading of specimens, and PCR amplification. Now, analysis of the result. If there is typical S-shaped amplification curve detected at FAM and or ROX channel, and the amplification curve which is detected at Sci-Fi channel and CT40 or less, then the test is positive. And if there is no typical S-shaped amplification curve, no CT or CT more than 40 detected at FAM and or ROX channel, and the amplification curve, which is detected at Sci-Fi channel, CT40 or less, then the test is negative. Now come to results. The figure shows detection rate of 2019 novel coronavirus by real-time reverse transcription polymerase chain reaction at Mymensingh division. Here, out of 356 cases, only 1,086 cases were positive, and it was about 7.5%. The figure shows distribution of patients with SARS-CoV-2 infection by sex in Mymensingh division. Here, maximum sex was male, that is 65.9%, and only 34.1% patients were female. The table showing age-wise distribution of patients with SARS-CoV-2 infection in Mymensingh division. Here, maximum positivity was found between the age 31 to 40, which is about 35%, followed by the age between 21 to 30, which was about 28.7%. Less positivity was found in the age group between 81 to 90 years. The table shows district-wise distribution of patients with SARS-CoV-2 infection in Mymensingh division. Here, out of 1,086 positive cases, maximum positivity was found in Mymensingh division and Mymensingh district, which was about 50.4%, followed by Netrokona, which was about 23.3%. After that, Jamalpur, Sherpur, and Sunamganj, respectively. Discussion. Current COVID-19 pandemic presents a serious public health crisis, and a better understanding of the scope and spread of the virus would be aided by more widespread testing. Different findings of the present study were compared with other studies in home and abroad. Now, conclusion. The world has been devastated following the outbreak of a novel infectious disease known as coronavirus disease or COVID-19. The present study revealed that COVID-19 has not yet ended. So far, the Bangladesh government has been fighting against the SARS-CoV-2 with its limited capacity and resources. Detection rate of SARS-CoV-2 by real-time reverse transcription polymerase chain reaction from nasopharyngeal swab is quite satisfactory and accurate one. The final diagnosis rate is high in areas with high positive rate. This is the first baseline study for genetic detection of 2019 novel coronavirus in Mymensingh division, which may reflect the total scenario of Bangladesh situation. As COVID-19 is considered as a global health threat, it still needs to be investigated deeply for all affected districts of Bangladesh. Recommendations. Further extensive molecular study, including gene sequencing of the PCR positive samples, should be done on national level to determine the genetic makeup of the infective viral strains, which will guide the researcher to formulate appropriate vaccine to combat this deadly pathogen. Limitation. Due to lower sensitivity of real-time reverse transcription polymerase chain reaction for 2019 novel coronavirus on nasopharyngeal swab, many positive COVID-19 cases was not actually detected. So, this present detection rate may not reflect the actual disease burden in Mymensingh region. Thank you all for your patience hearing.
MMC disconnect করে আবার কানেক্ট করবেন প্লিজ।
Thank you, Dr. Nazia Haq, for your presentation.
ডিসকানেক্ট হয়ে গেছে।
Yes, sir.
Mr. Shajid, can you hear me now?
Yes, sir. I can hear.
How long we are disconnected actually?
Sir, you can continue, please.
Okay. Now the floor is open for comments and question on Dr. Nazia Haq's presentation.
Assalamu alaikum. I am Rashidul Islam Deep, Department of Community Medicine, MPS student. I have a question. The question is why Mymensingh is more affected area in compared to other districts?
Thank you very much for your nice question. Actually, Mymensingh district is a large and overcrowded district, and it is the second mostly densely populated country. And the test, which was performed in Mymensingh Medical College in the Department of Microbiology, and there is a large tertiary government hospital present in Mymensingh. So medical professional and general population of Mymensingh district have got the opportunity to test more. So sample size was more in Mymensingh district, and positivity was also high in Mymensingh district.
Thank you.
Assalamu alaikum. I'm Dr. Saima Mujahid Lija, MP student, Department of Community Medicine, Mymensingh Medical College. Thanks, ma'am, for your nice presentation. I have a question, and the question is, why are children less affected by coronavirus?
Thank you very much. Actually, children had mild asymptomatic infection and were not detected, and or sometimes less likely to be detected. And their viral load is sometimes very low. And in our study population, total number of children was also less. So the percentage was slightly low in case of children.
Thank you. Any more comments?
শোনা যাচ্ছে? হ্যালো, শোনা যাচ্ছে? Can you hear me?
Okay, sir. Okay, sir. We can hear you.
Okay. Sorry, I can follow the session from the beginning, so maybe I have missed that part. But my query is the sample size only contain the case and contact, or it is mixed with some other foreigner or without case and contact, some who want to go to abroad? This is mixed with two kinds of population, so the actual percentage, detection percentage may be diluted 10%. And my second question is, in your lab, do you follow any pool method for detecting the case, RT-PCR case? Any pool method from the reagent? Mix the sample and then find the positive case, then if that is a positive, then individually test that. This is my two questions. Can you understand?
Sir, the answer,
One is
the answer of
is the sample is only the case and contact in your sample, only case and contact of coronavirus, or they are mixed with other population who want to go abroad. So the actual positiveness is diluted. That is only 10%, 14,000 to 10%. All these 14,000 are case and contact, or they are mixed.
Thank you very much, sir. I understand your question. Actually, in Mymensingh Medical College, that real-time RT-PCR was start in 1st April, and my data was from 1st April to 31 May. And in this first month, we only collect sample from cases or who are suspected for cases. But after 2 months, we have collected samples who also wants to go to abroad. But in first month, only the suspected cases, these are the samples.
So do you have separated from the first month, what is the positivity and in the latter month? Any such comment? How is it diluted?
In recent time, it is diluted. In the first times when we first works on this, in that time I think it was slightly more, because in that time we collect samples only from the suspected cases. But afterwards we collect samples only not for suspected cases, only not for suspected cases, and also from the person who wants to go to abroad or other screening test for doctors. So first month and first few months it was high, and after that it becomes diluted. And I think sir, now people are not interested to give samples. They were crazy in the first few months, but I think now disease condition is low and people are not as interested.
So my question, my suggestion, do you have any suggestion to the authorities to separate it? What is to the case and contact, and that who wants to go to abroad? These two people of I am saying Dr. Shamal Kumar Pal, sir, do you have any advice such kind that this is diluting of the result? They are decreasing. Do you have any suggestion or will advice such kind from this, from your data or your session?
Sir, I think this must be separated. Otherwise, the result will be diluted. So, case and contact person should be recorded in a separate sheet, and the peoples who are going to abroad, they should be another data sheet. Then the results will not be diluted.
Okay, thank you. This is my advice also.
Thank you very much, sir.
Thank you, sir, for your question. Any more comment or question from Rangpur Medical College? Madam, please. Madam, আপনি মাইক্রোফোনটা আনমিউট করে নেন, আমরা শুনতে পাচ্ছি না. We can't hear you.
Thank you for your nice presentation, Najia Apu. আমি ওনার কাছে একটা কোশ্চেন I have one question. How many asymptomatic case in Bangladesh have within 11 months? এভাবে কি কোনো করা হচ্ছে যে asymptomatic case কতগুলো আছে বাংলাদেশে যারা পজিটিভ?
Thank you, madam. Actually, this is my published article. And regarding Mymensingh situation, till yesterday, 77,435 cases, and out of them 7,592 are positive, and total positivity was 9.8%. This is last 11 months report in Mymensingh, but I cannot obviously tell you about the whole Bangladesh situation. This is about Mymensingh data. Total positivity from last 11 months, it is 9.8%. And it is more in first few months, but from the last few months, it is declining.
আপু 9% এর মধ্যে যে পজিটিভ মধ্যে কতজন সিম্পটোমেটিক কতজন অ্যাসিম্পটোমেটিক এরকম কি কোনো কিছু করা জানেন আপনি করছেন আপনারা?
Our inclusion criteria was patients having either history of sore throat, fever, or contact history. Most of the patients were symptomatic, but very few patients were asymptomatic who wants to go to abroad or who have to want to screening test. But most of the patients were symptomatic.
Thank you, Appa.
Thank you, madam. I think we are in shortage of time. Now it is time for Rajshahi Medical College. I would like to invite Dr. Nilufar Yasmin from Rationale Medical College to present her topic. She is going to present on perception on biomedical research and barrier to its practice of postgraduate medical students in Bangladesh. Dr. Nilufar Yasmin.
Thank you very much for giving me the opportunity to speak to and dear audience. Assalamualaikum.
ম্যাডাম আপনি শুনতে পাচ্ছেন নাকি মাইক্রোফোনটা কাছে নেবেন
এটা দেন স্যার এটার সঙ্গে
সাউন্ড একটু বাড়াতে হবে
Thank you very much for giving me the opportunity. Respected chairperson and dear audience, Assalamualaikum. I am Dr. Nilufar Yasmin, MPA student, PhD in DGHS in Attachment, Rationale Medical College. The title of today's presentation is Perception on Biomedical Research and Barriers to its Practice of the Postgraduate Medical Students in Bangladesh. Introduction. Research is a prerequisite for any field of scientific and social development. So it is applicable for medical science. The knowledge of research is applied in promoting health, preventing disease, disability, and death. Thus, research helps the way of development. Today's health research is tomorrow's health care. Biomedical research is the backbone of rapidly evolving world of medical science. Research training is a critical component of post-graduation course curriculum. But in these aspects, we are not up to date as developed countries. It is necessary for every doctor to keep their knowledge up to date for providing best services to patients. And for this purpose, research is mandatory. Postgraduate medical students are the beginners in the field of biomedical research. So it is very essential to assess their perception on research and the barriers faced by them during conducting biomedical research. Rationally, in current prevailing system of medical education in Bangladesh, research does not form an essential component in undergraduate curriculum. However, a postgraduate medical student can earn a little only after carrying out research work in the form of an academic research activity. Lack of exposure during the undergraduate level forms a major obstacle to postgraduate academic research activities. Also, inadequate knowledge of newer on research and lack of funds form major barriers in carrying out medical research. So, to assess perception on research and to identify barriers during conducting research among postgraduate medical students in Bangladesh is a time-demand issue. Research question. What are the perceptions regarding biomedical research of the postgraduate medical students in Bangladesh? And what are the barriers to practice biomedical research of the postgraduate medical students in Bangladesh? General objective: to assess the perception on biomedical research and barriers to its practice of the postgraduate medical students in Bangladesh. Specific objectives are to find out the socio-demographic characteristics of the postgraduate medical students, to assess knowledge on biomedical research of the postgraduate medical students, to assess attitude towards biomedical research of the postgraduate medical students, to find out the barriers faced by postgraduate medical students during conducting biomedical research, to find out the relationship of knowledge, attitude, and practice on biomedical research with socio-demographic and professional characteristics of the postgraduate medical students. Independent variables were there were some independent, dependent, and background variables, methods, and materials. This was a cross-sectional type of descriptive study. Study period was 1 year from January to December 2020. The study was carried out in the Department of Community Medicine, Rationale Medical College, Rationale. Data were collected from different medical colleges and universities all over the Bangladesh. All postgraduate medical students in the courses of PhD, MD, MS, FCPS, MPhil, MPH, and Diploma of different medical colleges under different universities in Bangladesh were study population. Doctors who were studying in different post-graduation courses all over the Bangladesh and who gave voluntarily consent to participate in the study were included in the study. Postgraduate students who refused to participate in the study were excluded. This was the formula by which sample size was calculated in the study. The calculated sample size was 658 and collected sample size was 325. Purposive sampling technique was employed to include the required number of postgraduate students. Self-administered, semi-structured questionnaire and Likert scale scoring were used to collect data from respondents. Consulting with the supervisor and reviewing the previous published literature, the research instrument of the study was developed. For assessment of perception, perception was divided into 3 subcategories: knowledge, attitude, and practice. In knowledge part, there were 50 structured questions with binary responses: 0 for negative answer, 1 for positive answer. So minimum knowledge score was 0 and maximum knowledge score was 50 for each respondent. Then this knowledge score was divided into 5 categories: poor knowledge was scored 0 to 10, fair knowledge was scored 11 to 20, average knowledge was scored 21 to 30, good knowledge was scored 31 to 40, and excellent knowledge was scored 41 to 50. For assessment of attitude, there were 15 statements in Likert scale and score was 1 to 5 for each statement. So for each respondent, minimum attitude score was 15 and maximum attitude score was 75. Then this attitude score was divided into 3 categories: negative attitude who scored 15 to 30, neutral attitude who scored 31 to 59, and positive attitude who scored 60 to 75. For assessment of practice, there were 13 questions with binary responses: 0 for negative answer, 1 for positive answer. So maximum practice score was 13 and minimum practice score was 0 for each respondent. Then this practice score was divided into 3 categories: no practice who scored 0, poor practice who scored 1 to 7, and satisfactory practice who scored 8 to 13. For assessment of barriers during conducting research, there were 15 statements in Likert scale and score was 0 to 2 for each statement. So for each respondent, minimum barrier score was 0 and maximum barrier score was 30. Then barrier score was divided into 3 categories: no barrier who scored 0, minimum barrier who scored 1 to 15, and maximum barrier who scored 16 to 30. A questionnaire was prepared according to the objectives of the study. Pre-test was carried out among 15 postgraduate students. After pre-test, some correction was done. Then respondents were briefed about the purpose of the study prior to data collection. Then data were collected through self-administered questionnaire. After collecting data, the completeness and internal consistency of the questionnaire were checked. The Google Forms were converted into Excel sheet. The data were cleaned by editing, coding, recoding, and categorizing. Data were rechecked to detect errors and to maintain validity. Then Excel sheet were converted into a Spaces file. All data were analyzed by using Spaces software version 24. A p-value equal to and less than 0.05 was considered statistically significant. Prior to the onset of the study, ethical clearance was taken from Ethical Review Committee of Rationale Medical College. Utilization of the study. The study will motivate postgraduate medical students towards research. The study will help policymakers to change curriculum in undergraduate level, and biomedical research will be a compulsory subject in undergraduate level. Results. Majority of the respondents were in the age group of 31 to 40 years. Most of the respondents were male. Majority of the respondents were Muslim. Most of the respondents were in MD and MS course. Majority of the respondents were involved in thesis for their academic purpose. Most of the respondents completed their MBBS degree from Government Medical College. Most of the respondent father were honors and master degree holder and mother were secondary and higher secondary pass. Most of the respondent father were government service holder and mother were housewife. 89.2% respondent were married. Most of the respondent spouse were MBBS and BDS degree holder and professionally they were doctor. Majority of the respondent had good knowledge on biomedical research and the percentage was 44.6%. These were first 10 points on which data were collected for assessment of knowledge on biomedical research. Similarly, these were second 10 points, third 10 points, fourth 10 points, and fifth 10 points on which data were collected for assessment of knowledge on biomedical research. Majority of the respondents showed positive attitude to biomedical research and percentage was 58.5%. These were 15 statements in 5-point Likert scale on which data were collected for assessment of attitude to biomedical research. Most of the respondents had poor practice of biomedical research. These were 13 questions on which data were collected for assessment of practice of research. Most of the respondents used online techniques such as PubMed Hinari for searching of medical journal. Majority of the respondents had no training on biomedical research. 86.8% respondents had no publication on journal, and this is an alarming issue for us. Most of the respondents faced maximum barrier during conducting biomedical research, and the percentage was 84%. These were 15 statements in Likert scale on which data were collected for assessment of barriers during conducting biomedical research. There was no statistically significant relationship between age and score of knowledge on biomedical research. The table reveals the association between socio-demographic variables and level of knowledge on biomedical research. And there were 3 significant points. Students of PhD and MPH course and who were involved in research and who passed MBBS from Government Medical College had more good to excellent knowledge on biomedical research. There was no statistically significant relationship between age and score of attitude to biomedical research. The table reveals the association between socio-demographic variables and level of attitude to biomedical research, and there was only one significant point, and that was male respondent had more positive attitude to biomedical research. There was statistically significant relationship between age and score of practice of biomedical research, and respondents who were above 35 years had more satisfactory practice of biomedical research. The table reveals the association between socio-demographic variables and level of practice of biomedical research, and there were 2 significant points. Respondents of PhD and MPH course and who were involved in thesis for their academic purpose had more satisfactory practice of biomedical research. Conclusion. Though the study reveals that knowledge level on research of postgraduate students is good, but their practice on research is poor. So postgraduate students should be concerned about research practice. Recommendations. A separate module of 1 to 3 months duration research training should be incorporated in the post-graduation course curriculum. Thesis or dissertation should be included in diploma courses. A system of rewarding for best thesis study may be started for encouragement of postgraduate medical students. Students' scientific journal should be established in every academic institute. Limitations of the study. Purposive sampling technique were selected. Sample size was 658, but 325 samples were collected. The study was conducted during limited period of time, enrolling smaller number of respondents. Due to COVID-19 situation, Google Form was used for data collection, so direct reaction of the respondent on the study topics was not identified. This was the Harvard system referencing style which was used in the study. Thank you all for your session setting.
Thank you, Dr. Nilufari Yasmin, for your presentation. I think it was your thesis in MPS program.
Yes, sir. Yes, sir.
Okay. Now the floor is open for comments, question or suggestion. Anybody from any connected site?
Excellent presentation. And right now doing a PhD in biomedical research is very much required in this COVID times. Can you hear me?
Yeah, we can hear you, but
it is very much required because
cannot see you.
You're able to see me? It is very much required because this COVID times innovation is required because of social distancing and other things. Every specialty requires where you can record the images and transfer the images without loss. So that is a basic requirement which is there. And lot of innovations are happening in biomedical research because equipments have to be changed where the equipment which is doing the diagnostic will have to record the photos also for transmission. And a PhD program is very good because you take up a particular equipment or something where you can work on the equipment for the past 2-3 years. And research is very much required in that field.
Thank you, Sheila.
And now online education is also there for them to educate themselves in various aspects, statistics and others.
Thank you, Sheila, for your encouraging comments.
I can see Dr. Rationale sir from Rangpur Medical College. I want to hear from you, Rationale sir.
Thank you. I am absolutely untouched about this matter. Our madam, the head of the department, he is knowing about this. The presentation is very excellent. But I want to see if I want to make a question. What about the undergraduate, especially in our department? How can we develop our research, our curriculum to initiate the qualitative research of our undergraduate student?
Thank you, sir. May I take the opportunity as I was the co-supervisor of her. Actually, this question you have asked is very valid question, but it was beyond the scope of her study. Actually, she was observing the biomedical research opportunities and the barriers among the postgraduate students. So it is a very valid thing, the knowledge and attitude and practices of not the students, the teachers, those who have been teaching in undergrad students, whether they have sufficient knowledge or what are their attitudes, or the authority who have been providing, who have been developing this curriculum, whether they are acknowledging this issue that qualitative research should be incorporated as a separate issue in undergraduate curriculum. So we have taken your comments very seriously, and we will like to, with you and with other public health personnel and teachers in several institutions, with the leadership of Jawad sir, we can have an advocacy meeting with the curriculum developing authorities so that they can include this research-related issues and include qualitative research component and arrange some training for the community medicine teachers in our country so that they can provide sufficient knowledge to the students. Thank you, sir.
Thank you, sir.
Professor. Okay, sir.
I have another question. In the community medicine department, those who are teachers, including assistant professor, professor, and also the lecturer also, it will be very qualitative and it will be very devoted also. Not for the, not, I think, not for doing the job. I think Professor Jawad sir, I respect him very much. To the teachers related minded in the others faculty, and especially the community medicine faculty, is quite a bit difference.
Thank you, sir. In the next time, I will try your suggested topics to do as a research.
Hello.
Thank you. Professor Dr. Shoilendra sir from Khaja Yunus Ali Medical College. Sir, any comment on this session or presentation of Dr. Nilufar Yasmin? Sir, unmute. Please unmute your microphone, sir. We cannot hear you, sir. I think sir is disconnected. Any more comments from any corner?
I'd like to make one comment. I think
Yeah, of course.
basic data collection and basic statistics should be included in the undergraduate curriculum. Only then when they come to the postgraduate level, they'll know what data collection is, what basic statistics to be followed. So that should be included.
Thank you, Sheila. It's a very good comment regarding our undergraduate medical research. You know, even in new nursing curriculum, they included an independent study for each student. So if the nurses can do a separate independent study in undergraduate curriculum, so why not MBBS student? So I think it is the time that we have to think about the some basic research in our undergraduate medical curriculum. Thank you very much.
Thank you, sir. I think Professor Dr. Shoilendra sir is connected again. Sir, any comment on this session?
Yes, thank you very much. And very good afternoon to all the organizers and participants. The session was very informative. We have been ourselves through this session from Shankar Netralaya postgraduate student. A very good initiative, and I must thank all the participants from the core of my heart. It is very useful, and I think most of the participants will be encouraged to present like this, and we have been enriched through these sessions. Thank you, everybody.
Thank you, sir. Professor Jawad sir, any comment on overall APAN public health session?
এটা সত্যি এটা একটা আমি বলবো যে আমাদের এটা একটা বড় অপরচুনিটি যে এইভাবে আমরা যদি রেগুলার ইন্টারভ্যালে আমরা যদি এরকম প্রেজেন্টেশনের ব্যবস্থা করতে পারি এবং আমাদের নিয়ার বাই কান্ট্রির এক্সপার্টদের আমরা ইনক্লুড করতে পারি, তাহলে আমাদের ভিউজ এক্সচেঞ্জ অফ ভিউজ সেটা প্রপারলি হবে এবং আমরা আমাদেরকে ডেভেলপ করতে পারবো। এবং যে কোশ্চেনটা এসছে আন্ডার গ্রাজুয়েটে আমাদের যে কারিকুলাম রিসার্চের ব্যাপারে আমাদের একটু কাজ করা, আমাদের স্কোপ আমাদের তৈরি করে নিতে হবে। ইভেন আমরা যদি অ্যাটলিস্ট কয়েকদিনের একটা প্রোগ্রাম করে একটা রিসার্চ শুধু আমাদের নতুন টিচারদের জন্য, যেটা ডক্টর রওশন বলছিলেন, এটা যদি আমরা বিভিন্ন ইনস্টিটিউশনে এটা তৈরি করতে পারি, আমরা হেল্প করবো, অসুবিধা নাই, আমরা নিজেরাও যোগ দেবো সেগুলোতে। তবে আমাদের এগিয়ে আসতে হবে। অ্যাজ এ হোল ইন জেনারেল এটা হয়তো এই মুহূর্তে আমরা দাবি করতে পারছি না বা আমরা সরকারকে ওইভাবে বুঝাতে পারবো না, কিন্তু আমাদের ইনিশিয়েটিভ নিতেই হবে, কারণ এটা এখন সময়ের দাবি। রিসার্চ করতেই হবে, রিসার্চ ছাড়া কিন্তু কোনো ডেভেলপমেন্ট মেডিকেল সায়েন্সে আশা করা যায় না। আর এই সুযোগে আমি একটা অপরচুনিটি নিয়ে আমাদের প্রফেসর শৈলেনকে আমরা সবার পক্ষ থেকে সে রিসেন্টলি ফুল ফ্লেজেড প্রফেসর হয়েছে এবং তার প্রফেসরিয়াল বোর্ডে থাকার আমার সৌভাগ্য হয়েছিল। তো আমি আমাদের পক্ষ থেকে, আমরা রাজশাহী মেডিকেল কলেজ ইনক্লুডিং আদার্স যারা আছে সবার পক্ষ থেকে শৈলেনকে আমি অভিনন্দন জানাচ্ছি প্রফেসর হিসাবে। আর
Congratulations,
from Shankar Netralaya, Dr. Jain, it's a very that we are very much interested to see her in different type of representation. But similarly, if we have such type of presentation in future, and we can include our other expert from abroad, we will be benefited. Thank you very much.
Thank you, sir.
Thank you, sir.
Professor Dr. Jawadul.
সরি, আমি এটা শেষে আমি ডক্টর কামরুজ্জামানকে ধন্যবাদ না দিলে এটা আমার অপূর্ণতা থেকে যাবে, যে সে সুন্দর একটা অ্যারেঞ্জমেন্ট করেছে এবং এই অ্যারেঞ্জমেন্টে আমরা সবাই যুক্ত হয়েছে। এই বেনিফিটটা তাকে আমাকে দিতেই হবে। ধন্যবাদ কামরুজ্জামান।
Sir, next time after 6 months, I am expecting participation from Rangpur Medical College, Rajshahi Medical College, Khaja Yunus Ali Medical College, and all other institutions who are connected. I shall communicate in future. Thank you all participants. Actually, all the presentations are informative, and we enjoyed the discussion session. At the end, Mr. Shajid will provide a link for evaluation of the session. Everybody please enter into the link and fill up the form or evaluate the public health session. Dr. Sheila, the last comment from your part. Last comment from your part.
Yeah, I was very happy to participate in this session. Thank you very much for giving me the opportunity.
You're welcome. Today's session is going to come to end. I would like to request Mr. Shajid to provide the link for evaluating the public health session.
Yes, sir. I already sent the link in the chat box. Please check your inbox, chat box.
Okay, thank you very much, Dr. Kamruzzaman and Engineer Shajid. Thank you enough.
Okay, sir.
You are welcome, sir. Everybody please check the chat box and fill up the link for evaluation of the public health session of Asia Pacific Advanced Networking 51. Thank
Or
you.
you can scan the QR code so that you can directly go to that.
QR code is displaying. You can scan and go to the link.
Scan করে কিভাবে এটা? এটা কি থেকে
মোবাইলের ক্যামেরা দিয়ে
স্ক্যান এটা কিভাবে করে?
Mr. Shajid, please give instruction how to scan. I think somebody is facing problem.
মোবাইলের ক্যামেরা দিয়ে আপনি স্ক্যান করতে পারবেন যদি আপনার স্মার্টফোনে ক্যামেরা দিয়ে।
Or you can write down the link in short and then separately enter into the link. You also can write down the link shown in the display.
Yes, sir. You can write this.
ম্যাডাম এটা করেন, এই লিংকে আমি আপনাকে ইমেলও করে দিব না, এটা ঢুকে জাস্ট কয়েকটা প্রশ্নের উত্তর ইভালুয়েশন অ্যাসেসমেন্ট।
আমার তো অলরেডি একটা হয়ে গেছে, আরো দুইটা আছে।
তাহলে আমি শেষ করে দিলাম স্যার। সো থ্যাংক ইউ অল।
না, জায়গা থেকে আমার নাম